Welcome back to the P3 podcast. As always, I'm your host, Talisha Reeve, and today we're going to be discussing how we can build confidence when discussing treatment costs with our clients. So if you're someone who feels uncomfortable when discussing the cost of various treatment interventions with your clients, you may be inadvertently impacting the quality of care that you provide, and to some extent you may even be sabotaging the treatment outcomes that you could potentially achieve. So the main concept about this that we're discussing today is it is actually possible that in caring too much, we can sabotage our treatment outcomes. So let's discuss. The Progressive Podiatry Project, here to share knowledge, insights and information for you to improve your clinical practice and, most importantly, help you help your clients. Now, by getting more comfortable with discussing some of these more uncomfortable topics, we're actually able to improve the quality of the care we provide and subsequently improve our treatment outcomes. Now, I say this as someone who genuinely wishes I could work for free, because I wish that there was 100% equity in healthcare, that the best care wasn't just available for those that have the deepest pockets. Now, I also say this coming from the perspective of someone who years ago I was noticing that I was changing how I was framing and phrasing and discussing different treatment interventions with patients based on assumptions I was making about their financial position. So I know some of us are bleeding hearts when it comes to our patients, and yes, it does make us really good clinicians. But in some respects, it can actually impair how we're achieving or working towards a positive outcome, because we are making assumptions on this. And if we're not recommending a treatment, or we're hesitant about recommending a treatment because of the cost, we're actually doing our patients a disservice by making these assumptions and changing how we're framing things, because it does impact how they receive and perceive the information that we're giving them. So I have over the years worked with a number of different business coaches and mentors, and not just in the podiatry sphere, because I very much am of the opinion that we need to step outside of our sphere of influence, essentially. So I've learned from business coaches that have nothing to do with healthcare. I've learned from physiotherapists. I've learned from podiatrists. I've learned from people that are younger than me, people that are older than me. So many different people. There's always something we can take away from a mentorship relationship, hopefully. Anyway, so I was finding that I needed to actually change my mindset and how I was bringing myself to some of these situations, because it was impacting how I was framing things. So I guess that was one good thing, that realization that I was doing that, which subsequently led to me just paying various people to kick my ass into gear and change my mindset. So I was actually delivering more consistent quality care to my patients. And this is actually quite reflected in the LinkedIn poll I put up last week. So I do this quite often, as many of you know. I will often share a poll or just get some feedback from my various networks. Oftentimes it's on LinkedIn. Also, if you do want to connect with me on LinkedIn, it's Talisha Reeve, very easy to find. Anyway, so I put out a poll, and it was essentially, how often do you find and how much do you find that discussing treatment costs impacts how you actually frame things and just impacts the quality of your care? And how much does cost influence what you're doing in clinical practice? Now, for some people, it was about a third of the respondents said a lot, it affects them. Then the middle ground, it was also about 35 to 40% said that it affects them somewhat. And then we only had about 30% that said it doesn't affect how they discuss treatments with their patients. So we've got about 2/3 of clinicians. And again, this isn't a literature publication, it was a LinkedIn poll. But anyway, so out of a handful of people, we had about 30 odd that responded. So we had about 20 of the 30 that said that cost does impact how they bring themselves to the equation when it comes to discussing treatment costs. So a good way to think of this is we always have room for improvement, right? And what makes us great clinicians, our empathy, our compassion, our genuine want to help others, that's what can actually be underpinning or undermining our ability to help them to the best of our ability when we're making assumptions about their financial position. So a quote that I'm borrowing from Tom from Paramed is that we're treating patients, we're not treating wallets. And making an assumption about someone's financial position and not giving them the full amount of information that we may be able to provide as far as a treatment goes, that is actually doing them a disservice from us being, in our minds, caring about their financial position. Because again, it's not our responsibility to take that burden on board or make assumptions about that burden. So we will get into some ways that we can help navigate this. So another thing is, I do recognize that we all work in vastly different locations. So all of the locations we work in, they have their own unique cultural backgrounds, socioeconomic backgrounds and demographics that exist. So for some people, cost doesn't really factor in too much because the vast majority of their patient cohorts are potentially able to afford whatever treatment options are available. And then we do have other clinics and demographics that we work within where we do need to be quite cost aware and patients are very price sensitive. So this isn't a one size fits all approach. It's just maybe a mindset shift and a strategy to how we can approach things better if we're finding that we're making these assumptions. So probably a good way to start is sort of with some examples. Now, so we're humans, so we take in a huge amount of information, not even consciously, about body language and inflections in voice, and just we're absorbing all of this other information when we're interacting with other human beings. And how we're discussing or raising the topic of the costs associated with certain treatments can actually impact how our patients perceive this. So when we're discussing something that we don't feel overly comfortable about, oftentimes we may, and guilt, I think that's probably one of the main feelings that I was experiencing when I was having these, or finding that I was having difficulty with these conversations. So when we're feeling uncomfortable, we tend to be less confident in our voice. So we might be speaking a little bit quieter. We might not make as much eye contact. So we may be looking away and our voice might drop a little bit. And so this intervention, it might help the heel pain that you've got. Like I know orthoses, like they do cost a little bit, but maybe instead of the orthoses, like we could just try some strapping for a few weeks instead. And if that doesn't work, then maybe we can have a look at trying the orthotic devices. So if we kind of just, like, I know some of you were watching and then some of you were just listening to that, but that there's an obvious change in the voice and the body language that was coming in there, and even just the stumbling on words. And then if we're going to, say, frame that a little bit more confidently with someone and we're not overly mindful, or we can be mindful, but we're not letting the discussion of cost impact what we're discussing. So it may be, okay, so based on your assessment today, I am pretty confident that it is plantar fasciopathy that we're dealing with. So there are a number of different treatments that can work or that may be effective for your presentation. So based on our assessment today, it is looking like that probably changing your footwear and potentially heading into some foot orthoses. So there are options available. So we may have prefabricated or custom orthoses, and I'll run through the sort of positives and negatives of both of them in a minute. So when we've got custom orthoses, because it's looking like, you know how I was talking about, we've got our tension-driven plantar fasciopathy where it's more of that strain, and then we've got the compression where it's more just that pushing down of gravity plus your heel onto the ground. Because you work on your feet on hard surfaces so much, I do feel that the compression part is forming part of the equation for you. Now, when we're dealing with prefabricated orthoses, we can't modify as much around the heel as we can with our custom devices. So I feel that with what's happening with your specific presentation, that if we were going to head into orthotic territory, custom orthoses would likely give us the biggest treatment benefit. So with that, they cost however much they cost. Prefabricated ones cost this amount. And either way, it's up to you. But in my opinion, I do feel, based on your clinical presentation, what we're looking to achieve and what you do for work and the changes in footwear, I think they would probably be most suited to orthoses. It's up to the custom orthoses. Now, it's 100% up to you, but I'm confident with this treatment approach, it's probably going to give us the best chance at getting the pain under control for you in probably the quickest amount of time. How long that takes, I can't give you a definitive answer, but that's probably where I would recommend. Now, it's 100% up to you, and I'm happy for you to shoot a heap of questions at me. If there's any alternatives that you may want to discuss, that's fine, but that's where I would probably recommend things going today. Okay, so they're two different contrasting examples. Now, it's more so the tone and some of the language and the confidence and that linking those goals in. This is your presentation, this is the treatment intervention, this is how they're going to work together. So off the cuff, it's probably not as individualized as I would do in the clinic. But anyway, it was just an example. So hopefully you can see even just the difference in the voice, the delivery, the stuttering, the confidence essentially. So when you're a bit more confident and it's a bit more straightforward, you've got a clear explanation and you're able to somewhat link the clients, their goals, but also their clinical presentation to the treatment interventions that you're recommending. This gives the patient the opportunity to understand why a treatment may be recommended despite the additional costs. So this is what the treatment is aiming to do, and it costs however much it costs. I know, especially orthoses, the cost of that varies wildly. Some people overcharge significantly, and I do think some clinicians undercharge significantly, but that's a debate we're not having today. So hopefully that gives you a little bit of an idea on how even just the body language and the tone of voice and some of the ways that we're delivering information can actually impact how a patient perceives this. So if we've got someone who is on the receiving end of us not being overly confident in what we're saying, they're obviously not going to be that confident in receiving that information. Like, oh, well, Talisha's hesitating on this. She doesn't seem confident with it, so it's probably not worth trying because it doesn't seem like it's going to work. Okay, so that's just a little bit of an example. So I'm going to just read out some questions for you that I included in the blog post that I wrote about this. And it's essentially to try and give you a little bit of a self-awareness twig for if you are guilty of projecting and making cost assumptions on behalf of your patient. So 1, how often do I avoid discussing higher cost treatments due to the concern about a patient's financial status? And factored into this is, do I leave it up to my admin staff to discuss price? So in a clinical setting, do you confidently discuss orthoses and where they fit into the equation, but you don't mention cost with your patient until they're out in the waiting room and the receptionists are going through how much the orthoses are going to cost, the scans, the fitting appointment, everything like that? If that's how you approach, you are guilty of this because you're avoiding and just passing that discomfort on to someone else. And you're also potentially running the risk of having an APRA complaint about you because you're not being transparent with the information that you're giving. It is a responsibility of us as the clinicians. Okay, so question 2, do I feel uncomfortable or anxious when discussing treatments with higher costs, even before the topic has been raised with my patient? So I'm about to start talking about orthoses. Oh God, I really hate this because I'm going to have to tell them that they cost $500, however much they cost. So if you answer yes to this, so the discomfort you feel may be stemming from your assumptions about how they're going to react to this, your assumptions about, well, are you confident that this is going to work? I'm not sure. So you may be making assumptions regardless of what it is, their financial status, the efficacy of your treatment. If you answer yes, you're probably assuming. So question 3, do I find myself making judgments about a patient's ability to afford treatments based on their appearance, their background, or their referral method. This is a big one. So have they been referred under an EPC? So oftentimes for people to be eligible for an EPC, chronic pathology and or financial stress in some instances. So if you answered yes, it may be a clear sign that assumptions may be impacting your treatment recommendations. Question 4. Do I feel relieved when a patient declines the higher cost treatment option? So if I've recommended custom orthoses versus prefabricated orthoses, even though I may be more confident with one versus the other, regardless of the efficacy of them, do you feel relieved if they select the cheaper option? And I think it probably requires more attention if you're relieved if they choose the cheaper, but also the treatment option that is likely going to be less effective. That's when we really need to do some self-reflection and change how we're bringing ourselves to the equation. So question 5, which is somewhat tied into question 4. So do I assume that a patient would rather opt for a less effective but more affordable treatment option? So when we're making this assumption, it really can impact what treatment options that we may present and also how we're presenting them. So a good way to think of this is like when you're online shopping and you can filter the shopping cart or not the shopping cart, you can filter the search results. So we've got, sometimes it's the newest or the most recommended or price, high to low or low to high. So I'm of the opinion that when we're discussing treatment options with patients, we should be starting with what is likely going to be the most effective and why it's most effective or why it may be the most effective for them, and then working our way back from there. So if that fails, then we may potentially look at this, then we may potentially look at that, then we may potentially look at that. And also talking about how they may all work for their individual pathological presentation. So if we're doing it the other way, so we're starting with the cheapest, and the cheapest may be the least effective for their clinical presentation, but we're starting with that because that's the most comfortable for us to discuss. That's not fair to them. And then number 6 is, am I being transparent about all available treatment options regardless of cost? If not, you may very, very much be presuming what your patients can and can't afford, and this is doing them a massive injustice and a disservice because we have a responsibility to give patients that ability to make an informed choice about their healthcare. So we need to be able to give them all of the available treatment options, all of the costs associated with that, and then help them navigate that process. So if we're recommending some treatment interventions that may be more expensive, and then the patient has a little bit of discomfort that they share or uncertainty about, I don't know how I'm going to be able to afford that, then after we've given the patient all of the information about the different treatments, the associated costs, if then they say something that raises a flag with us that, finance might be a barrier here, then there's a few methods that we can implement to try and help navigate that. But I would wait for the patient to raise that. It's not our job to raise that for them. So a little bit of an example of where a clinician may not be being transparent, maybe not so much purely because of that sort of internal price sensitivity and the assumption of price sensitivity. It's even their bias and experience. So we're not talking about humans here, we are talking about pets. My mum has this heart-crushingly adorable little puppy. He's 5 and a bit months old and has a limp that was progressively worsening over probably about 3-4 weeks. My mum took him to the vet, very country vet who mostly deals with farm animals. Took him to the vet. Vet did x-rays and basically it was, I'm really sorry. Yeah, just take him home. Enjoy the time you have with him. You've got maybe 6 months. We might take his leg off, and then in 12 months you'll have to say goodbye. He'll be ready to be put down. Now, she was absolutely crushed, as was I when I spoke to her, But what she relayed to me that the vet said, that was most of the conversation, and it was just off the back of an x-ray that he took, so called the vet, and puppy has avascular necrosis of the humeral head. So is it from trauma or is it genetic? Don't know. Doesn't matter at this point because it's there. And this vet did not discuss any form of conservative treatment. It was amputation and death. That was the option we had. There was no pain relief that was brought into the picture or anything like that. There was a recommendation that, you could take some anti-inflammatory, or he could take some anti-inflammatories, but that was it. And I called the vet and got a little bit of that sort of feedback. Okay, well, what is happening? Yes, it's avascular necrosis. Why are we not having any discussions about conservative treatment options? Humans experience this. We don't put babies down because they have a dodgy hip. And this isn't an avenue or opening for that discussion between, well, pets aren't the same as children. No, we're not doing that. There's so many reasons why we're not doing that, but this is just an example. So with this vet, he's very much a farm vet, and when I spoke to him, I was like, I don't understand your clinical reasoning. Why are we going from where we're at now to putting the dog down in a year? Literally the response was, well, the quality of life, like a dog with 3 legs, like they're not very good, so it's probably just easier. And then the next part was, well, I know your mum's a little bit attached to the dog, but he is young, so like it might be a bit easier. You can just put him down and then get another dog that doesn't have the problem. Like, holy shit, making that much of an assumption about someone just based on his bias, that's what he would do. So therefore, that's a treatment option he's going to recommend. So needless to say, not going back to that vet. And again, I know it's a different scenario, but it's just an example of how someone will actually alter what they're giving advice or treatments that they're giving their patients based on their internal bias, which is just not how we should be operating, because we have a responsibility, regardless of if you're a health practitioner or a vet, to give our patients, one, the most up-to-date evidence-based treatment options, but providing them with all of the treatment options so they can make an informed choice about their care that they're going to receive or the care that they're going to engage in for their puppy. So it's, again, a little bit of a different example, but it's just a real-world example that was happening literally this week. So the irony that I wrote this blog, then this happened, and now I'm recording the podcast on it. It was just very real. And it is, again, like we're talking about puppies and humans, but when we're making these assumptions and that's impacting what we're actually doing in the clinic and what we're recommending in the clinic, it has real world ramifications. Like the amount of distress and how upset we were for a couple of days until I got puppy into a different vet. Like the stress and the distress, it was very real. It was very tangible. It wasn't a nice few days. And it just, when we're doing a disservice if we're not remaining neutral and giving our patients the information that they need so they can make informed choices about the care and then help them navigate that process instead of just assuming and go, well, this is what I would do, therefore that's what I'm going to recommend everyone do. Anyway, so back to the human element that we're discussing. So yes, we need to be very transparent and open about everything. So we should not be recommending treatments or not recommending treatments because of our inherent bias and the lens that we're looking through. So we should be, for whatever the pathology or the clinical presentation that you're dealing with, be giving our patients all of the information so they can make their informed decisions. So discussing all of the available treatment options relevant to them, being transparent with all of the associated costs with the treatment interventions that are relevant to them. We should not be filtering. And then jumping back to what I mentioned earlier is, so that's one impact on the quality of care we can provide, is us even just discussing the type of care that we may be able to provide. But then also what I was mentioning earlier is how we frame it, how we deliver it. So it's no secret that perception and expectation can greatly influence our treatment outcomes. So if we demonstrate hesitancy or a lack of confidence, we can be inadvertently compromising the quality of care we provide. So if we're uncomfortable, so our discomfort, which again can be demonstrated by our body language, our demeanor, how we speak, the tone of our voice, how loud we're talking, all of this, if we're not seeming like we're confident and being sort of transparent in the information that we're giving, this can reduce the patient's level of trust in our expertise and also the treatments that we're recommending. So it can impact. So if we're not confident with, and it's not this fake it till you make it, like if you don't think something is going to work for someone, be honest about that. But it's, so don't downplay something, don't inflate something based on you sort of trying to get a sale over the line. It's no, just being transparent and genuine with the information that you're providing. So we just need to be aware that if we're trying to come from a well-intentioned place of being a little bit coy and shy about talking about the price of things, we can actually be impairing or impacting the quality of care that we provide. So as health practitioners, it very much the level of confidence that we demonstrate, it really does matter. So it influences how our patients perceive us. It influences their acceptance of the advice that we provide, and ultimately it does impact their health outcomes. So I want to get to a couple of strategies that you may be able to employ to try and improve your confidence in this area. So earlier, yes, we did ask ourselves some questions at, am I guilty of feeling guilty? Which is, am I guilty of sabotaging to some extent some of the treatment outcomes that we may be able to work towards? So the first one is detachment. Now, this is one that I still have to remind myself of quite often, especially if you do have someone that you do know they are a bit price sensitive because of interactions that you've had before. You can be aware of this, but again, we may be inwardly very aware of this, and inwardly we may not feel great about having this conversation, and we may feel a little bit uncomfortable, but outwardly we need to show or demonstrate detachment. So we need to remain neutral. So Tom, again, stole this quote from you. So remember, we're treating a patient, not their wallet. So we need to remember that we're not deciding for the patient, we're providing them with options. So the best thing that we can do is remain neutral, remain detached, give them all of the available information. That is the best thing that we can do. Then if after discussing the associated costs for some of the treatments you've discussed, then we may have some discussions about navigating the affordability of those treatments. So a good way to look at this, jumping back to the example of my mum and the puppy. So if you were in the patient's position, would you rather, or would you want to be provided with all of the available options and the associated price, or have the information that is being shared with you curtailed? Or so a really good way to think of this is, if you were in the patient's position, would you want to be provided with all of the available treatment options and their associated costs, or would you rather have the information being shared with you filtered based on the clinician that you're seeing, making an assumption about your financial position? I think we both know the answer to that. So that's probably the best thing to keep in mind that will help you remain, hopefully help you remain neutral when it comes to discussing this. We're doing a patient a disservice if we're not providing them with all of the information. Then if we find that financial elements or constraints are a barrier, we may be able to provide options to help navigate that barrier, but we shouldn't be making assumptions before we get to that point. So building upon that, so yes, we've provided our patient with all of the available treatment options. We've been quite transparent with all of the treatment costs, the costs associated with that treatment. So then we may need to, again, provide some options to help them navigate being able to afford the treatment if it is required for their treatment. So I'm talking to this from the context of podiatry and podiatric practice because that's what I work in. So in podiatric practice, it's usually orthoses and footwear that can be the most expensive treatment. There may be others. Ankle foot orthoses also fall into the orthoses category. But anyway, so when I owned and operated my clinic, it was in a region of a somewhat lower to mid socioeconomic status. So there was not a significant, but a notable portion of patients that finance was a barrier for them. So I did introduce payment plans for orthotic devices, and I would do this for custom and prefab orthoses. Now, depending on the client, not everyone would be offered a payment plan for prefabricated orthoses, but if you're because again, I wish I could treat everyone for free, but there were some patients that I would see that their pensioners are on a very low fixed income and affordability was very, very low for them. So they were in those situations. And again, I would sort of do it on a case-by-case basis. There were some people that I would let them pay off a $60 pair of orthoses over a number of weeks or months. But again, it's my decision. So it's you do you. I'm just giving you some ideas on how we can, I'm discussing some ideas on how you may be able to navigate this. So I introduced payment plans. Now, there's a couple of different methods that you could do this. So there are some organizations and services that you can utilize that they basically become the intermediary. So they will pay you and then the patient ends up with that sort of kind of loan associated with them. Because of what I was dealing with, the frequency of what I was dealing with, I just chose to offer the payment options myself and had the contractors between myself or my clinic and the patient. So there's a few different avenues. Again, this is sort of the general advice, depending on your clinic, your needs and what you need to navigate, how often you may be doing this, that's different. But payment options is a way that we can help our patients navigate this. So did I get burnt with it? Yes, but not as often as I probably thought I would. So I'd say out of the 7 years that I had the clinic, there were 2 definite instances where a client failed to pay off their orthoses, but it was one of those things. So I would always take a deposit. So when it came to especially custom orthoses, the deposit I would take, and I wouldn't send the scans off or the casts off until I had the deposit. And the deposit was usually enough to cover the manufacturer of the device. So that's how I would navigate it. So if someone didn't pay, at least aside from time investment, I wasn't really out of pocket for that, if that makes sense. But again, everyone's different. Navigate it how you will. So out of a couple of years that I had the clinic, there were probably only 2 times that people did not pay off the balance. Then there were a half dozen or so that they got a little bit slack and then they weren't following up with their payments and had to do a little bit of chasing up, which was a bit of a bugbear for myself and the admin staff. But usually if it was chasing, then sending a bit of a strongly worded letter, which was essentially based on the contract that you sign, you haven't paid, you're behind in your payments, this is going to be referred to a debt collection agency, and that got things back on track really quickly. So essentially, if you're concerned with a patient or some patient's ability to afford certain therapeutic interventions, it may be worthwhile looking into having payment plans available, but you just need to weigh up the pros and cons of are you going to defer this to an external service? Are you going to manage this yourself? It is quite different. And again, there's a number of individual factors that will drive your decision-making process for this, but that's definitely an option that we can help alleviate some of the stress for our patients and try and remove one of those barriers to affordability for healthcare. So, and then the last thing, which is what I've spoken about time and time again throughout this episode, is being transparent and compassionate. So focus on our soft skills and the communication. So what we want to do is we want to be transparent about the potential efficacy of a treatment, the costs associated with it, how it fits into their treatment plan, be compassionate towards them, because again, making assumptions either way isn't fantastic. But again, we just need to work on staying neutral in our body language, in our demeanor, how we're communicating to them. And another thing that I found quite helpful in the clinic is I would have printed off sheets that printed off sheets that outlined the treatment costs. And I did have flyers that I'd printed out that discussed the payment options. So if you find that there's something that's create a procedure for it essentially. So if you find that there's something uncomfortable that you discuss, if you can defer to a procedure that you may well have written, so you're essentially deferring to yourself, but you're deferring to this document or the piece of paper, it puts an removes you a little bit from that discomfort, if that makes sense. So similar to how if clinicians are uncomfortable with discussing costs, they may palm it off to the receptionist to have that conversation with the patient. You can also defer to a document. So this is the document, this is just the clinic thing, because it's not you sharing it. You're showing them and stepping the patient through. This is what that costs, this is what that costs, this is what that costs. These are options that are available. So when it's more documented and sort of procedure based, then that's where, again, you can create even more of that element of neutrality, because there is that disconnect between what you're saying because you're referring to a document, if that makes sense. So whilst this is no definitive fix on how to address the complex emotions that we may feel as clinicians looking to help our patients as much as possible, but hopefully if we can shift how we look at and make assumptions about the cost of healthcare, and we can come at it from probably, again, a more neutral but also a more confident place, hopefully it can improve the interactions that you're having with your patients, the feelings that you get, and even, well, hopefully improve the quality of care you provide. So before we leave off, I do have a big favor to ask you. If you are enjoying any of the episodes on the P3 podcast, it would be hugely helpful and hugely appreciated if you would be able to subscribe to the channels, leave a review, and share these episodes with your progressively minded colleagues, because the bigger we can get this platform to grow, the more time and effort I can put into the platform, because it helps support us in a number of ways. So thank you. I would love your feedback. Drop us a comment, or you can send me an email, p3podiatry@gmail.com. It's been great. I hope you've got a lot out of this episode, and I'll catch you next time. Cheers.